الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين سيدنا محمد. الليكتشر بتاعتنا النهاردة على need for mechanical ventilation in COVID-19 patient for non-pulmonologist. الأوز بتاعت الليكتشر دي هنتكلم فيها عن modalities of ventilation in COVID-19 patient, decision of intubation, precautions during mechanical ventilation, some points in ventilator management of acute respiratory distress syndrome, some points in weaning and extubation of COVID-19 patient. As we all know that SARS-CoV-2 is the cause of acute respiratory distress syndrome in the what known nowadays COVID-19 virus, which is resulting in the nowadays pandemic we are in. It causes acute viral pneumonitis, which resulted in acute respiratory distress syndrome, which is the main cause or the main need for mechanical ventilation in COVID-19 patients. There are many specific aspects of respiratory care relevant to deterioration of patients with COVID-19 before admission to the intensive care unit. This aspect is related to the rapid deterioration in the need of oxygen therapy, where the patient are admitted in the department on low flow oxygen, with the increasing in oxygen demand up to high flow oxygen or high flow nasal cannula or non-invasive mechanical ventilation, then invasive mechanical ventilation in the ICU. These change or gradual change in oxygenation or even the rapid change in oxygenation needs attention, as those patient is for ICU admission or for mechanical ventilation. The decision of ventilation differs in those patients. Nowadays it is the non-invasive modalities is better suggested than the invasive modalities in COVID-19 patient. So we said that a trial of non-invasive ventilation is reasonable in patients with COVID-19 who are in need for mechanical ventilation if there is no contraindication to non-invasive ventilation. The decision it is invasive or non-invasive, as many said that early invasive ventilation is better, depends on many factors, balancing the risk and the benefits to the patient, or the risk of exposure to the healthcare workers, and the best use of resources in the place they are in. When decision it is non-invasive mechanical ventilation using a mask, not endotracheal tube, the key for success of in those patients needing non-invasive mechanical ventilation is the frequent clinical and arterial blood gas evaluation every 1 to 2 hours to ensure the efficacy and safe ventilation. So close and regular follow-up about the potential for intubation so that the transition for intubation can be smooth and rapid. As we said, if I following my patient well, I will not never lose him or lose the stage when he needs invasive mechanical ventilation, and I will intubate at the correct time. So when to intubate those patients when there is rapid progression over hours, no improvement, lack of improvement on fraction of inspired oxygen more than 60%, evolving hypercapnia or increasing work of breathing, worsening of the mental status or hemodynamic instability and multi-organ failure. Precautions. Many precautions should be followed and strictly followed in intubation in COVID-19 patient, as intubation is the highest risk procedure for droplet dispersion in those patients. The first is performing rapid sequence intubation in those population, and this term used in the ICU or the place or the suite where COVID-19 patient intubation care should be taken, regarding the staff and the tubes and the care of the tubes and the emergency team, all are available and ready for rapid intubation using the personal protective equipment. All the staff in the room ready and wearing N95 respirator, mask, eye protection, gloves, protective footwear, neck covering, or even beard covering, or even double glove technique. Intubation should be performed in an airborne infection isolation room as much as we can. Intubation should be performed by the most qualified individual. When using manual bag ventilation, switching the mask to the supraglottic device for manual bagging is appropriate. A bacterial and high efficiency hydrophobic filter should be placed between the face mask and the breathing circuit or resuscitation bag. Also, a pre-prepared bag mask with a filter attached in every room with COVID-19 patient should be available. The ventilator and the ventilator circuit should be ready in advance with a pre-planned setting. The expiratory lamp on the ventilator should have a HEPA filter to decrease contamination of the ventilator environment and staff. Doffing should follow strict procedure. Most patients with COVID-19 who are mechanically ventilated appear to have acute respiratory distress syndrome, but accurate data on the duration of ventilation are limited, but there is suggested that those patients need prolonged mechanical ventilation than non-COVID patients for 2 weeks or more. Whether different phases of COVID-19 pneumonitis require different ventilatory strategies, this is unclear, as there is suggested 2 types of ventilatory of phases of COVID-19 pneumonitis, either L type or H type, which depends on the lung mechanics, compliance, and resistance. Ventilator management of acute respiratory distress syndrome in COVID-19 patient depends on the strategies that promote lung protection, lung protective strategies. The first of these lung protective strategies is low tidal volume ventilation, which is promoted to offer a tidal volume from 8 milli per kg predicted body weight and decrease down to 4 milli per kg to maintain a plateau pressure below or less than 30 centimeter water. Addition of supportive infusion norepinephrine to prevent hypotension associated with intubation during mechanical ventilation initiation. Any needed interventions should be done if it only will change the clinical management, as bronchoscopy. For example, no need except if it will change the clinical management for the patient. Permissive hypercapnia is permitted. There is improved mortality from low tidal volume ventilation in patients with ARDS. Modifications to or deviation from this mechanical ventilation strategy may be required in the setting of severe hypercapnia or ventilator dysynchrony. Failure of low tidal volume ventilation. Shifting the patient to prone ventilation is the preferred next step to improve ventilation perfusion mismatch in those patients. Prone ventilation timing or period suggested to be from 12 to 16 hours prone per day, and performing the maneuver at a change of shift when the sufficient staff are available. Optimal timing for discontinuing prone ventilation is unclear and should be performed on an individualized basis. Each patient has his special circumstances. Additional options when these mechanisms or previous lung protective strategies and the prone ventilation failed is recruitment maneuvers and high beep with titration of the beep of the patient with the low FiO2 as we can. Addition of pulmonary vasodilators may improve ventilation perfusion mismatch, especially in those with decompensated or acute pulmonary arterial hypertension, where pulmonary vasodilators don't improve mortality in all causes of ARDS. Adding neuromuscular blocking agent may be reserved for patients with refractory hypoxemia or ventilator dysynchrony, and we don't favor their routine use in any patient with acute respiratory distress syndrome since data on its outcome are conflicting. Extracorporeal membrane oxygenation is a rescue strategy and it is not universally available, and it requires the recruitment of additional specialized nursing and perfusionist staff. It is needed when there is refractory hypoxemia despite lung protective ventilation, or when PO2 on FiO2 ratio less than 80 for 6 hours or more, regardless the beep used, or there is severe hypercapnia which result in pH less than 7.25. Monitoring of invasive mechanical ventilation should be followed clinically, and the ventilator waveforms should be examined with intensivist or pulmonologist on regular basis so that the mood and setting can be adjusted according to the patient needs. Other several issues can non-pulmonologist take care of is the supportive care addressed, including sedation, hemodynamics, nutrition, prevention of ventilator-associated pneumonia or venous thromboembolism, which is common in patients with COVID-19, also gastric ulcerations management. Weaning and extubation. Weaning and extubation in COVID-19 patients should adhere and follow airborne precautions, including previous precautions during the intubation process. Needed extra staff in the room should be not present in the room to help to justify their presence if there is need only. The separation or the weaning of the patient on a T piece is not preferred, and he should be put on the least pressures needed on a spontaneous breathing trial till the extubation. To avoid post-extubation respiratory failure. Some use medications to decrease coughing, such as lidocaine via intratracheal tube or low-dose opioid bolus. In the ICU, close communication with a clinician experienced intubation with rapid intubation is needed, particularly for patients pre-designated as having a difficult airway. So post-extubation care is very important to avoid re-intubation in those susceptible to post-extubation respiratory failure again, or the need to high flow oxygen, or the increase of the fraction of oxygen needed for each patient, so expected re-intubation again can occur. So because patients are often extubated while they remain infectious, we would advise adhering to similar approach in oxygen delivery, and we must extubate those patients in a low flow oxygen therapy is better. And thank you.